Hello, dear students. Your topic is malabsorption syndrome in children. The syndrome of malabsorption is understood as disorders of digestion and absorption in the small intestine, which are based on genetically determined or formed with persistent damage defects in enzyme systems that lead to metabolic disorders. Genetically determined primary forms of malabsorption are usually inherited in an autosomal recessive manner, but may also be due to gene mutations resulting from various adverse effects on the fetus. Acquired secondary forms of malabsorption are the result of damage to the intestinal epithelium due to various disease, malformations of the gastrointestinal tract, resection of the small intestine, but may also be of extraintestinal origin, disease of the pancreas and liver, immunodeficiency states, some endocrine disease and tumors. Classification: intracavitary, when cavitary digestion is disturbed due to a deficiency of pancreatic enzymes, to a lesser extent. Second, it is enterocellular, when membrane digestion or absorption is impaired due to a defect in the enzyme systems of the enterocytes itself. And third classification is postcellular, when the process is localized in the submucosal layer, in the system of lymphatic vessels and capillaries, which leads to increased transudation of plasma proteins into the cavity of the small intestine. Enterocellular malabsorption with impaired membrane digestion, disaccharide deficiency. Disaccharide deficiency is the most common type of malabsorption. Usually it is secondary or transient. Congenital forms are much less common. The following variants of disaccharide deficiency are distinguished: lactase, sucrase, isomaltase. The last two are usually combined. There are primary and secondary lactase deficiency. Primary, genetically determined; congenital, rare; early, usually partial, after 3 or 5 years; late, for adult type, ethnically determined; and secondary, the result of damage to the mucous membrane of the small intestine, infectious enteritis, rotavirus, celiac disease, medicinal enteritis, radiation enteritis, and Crohn's disease of the small intestine. And also, transient lactase deficiency can be observed in most very preterm infants. In children with lactase and other types of disaccharide deficiency, incomplete breakdown of disaccharides occurs, which are not absorbed and entering the distal intestines, undergo bacterial fermentation with the release of hydrogen as a result of fermentation. Gas formation increases, the pH of the intestinal contents shift to the acid side due to the formation of fatty acids, mainly lactic, propionic, butyric, and acetic. The clinical picture of various types of disaccharide deficiency, both primary and secondary, is very similar and is characterized by attacks of intestinal colic, diarrhea, regurgitation, vomiting, bloating, loss of appetite, anxiety, insufficient weight gain, and as a result of malnutrition. The stools are rapid, watery, fruity, with much flatulence, sometimes green color with a sour smell. In the case of congenital lactase, there may be lactosuria, aminoaciduria, and sometimes hyperglycemia. The frequent detection of opportunistic microflora in the feces of patients sometimes leads to an erroneous diagnosis of acute gastroenteritis and the unjustified prescription of antibiotics. Secondary lactase deficiency develops at any age against the background of a protracted course of intestinal infections, especially rotavirus, food allergies, celiac disease. Clinical manifestations of fermentopathy may be indistinct due to the symptoms of the underlying disease. Therefore, anamnestic data on good or poor milk tolerance are crucial for diagnosis. Don't play. However, the abolition of milk as in congenital forms leads to an improvement in the child's condition. Diagnosis. The simplest method of diagnosing any type of disaccharidase deficiency, including lactase deficiency. Fatty acids iodophilic flora can be detected in the coprogram, but there are no inflammatory changes. Decrease in the pH of feces is possible only after a sufficient load of lactose, subject to repeat transit through the intestine and the absence of severe dysbiosis. Treatment. Treatment of lactase deficiency depends on age and severity. The slight degree of inhibition of the enzyme, which can be observed in gastroenteritis, more often of a rotavirus nature, it is sufficient to limit the intake of milk for several days, since the intestinal epithelium quickly restores its structure. In chronic bowel disease and rare congenital variants of lactase deficiency, low lactose mixtures are recommended. In severe cases, switching to lactose-free mixtures based on soy proteins which contain all the necessary ingredients are adapted in composition by adding amino acids, vitamins A, D3, E, C, P, B, vitamins group B, trace elements, carbohydrates in them are presented in the form of polymers of glucose or corn syrup. What is celiac disease, or gluten enteropathy? It is a chronic polysyndromic disease caused by damage to the mucous membrane of the small intestine by cereal protein gluten. Gluten contains wheat, rye, barley, oats. Grain proteins have 4 fractions in their composition: albumins, globulins, prolamins, and glutenins. The last 2 are called gluten. Celiac disease is inherited in an autosomal dominant manner. The main mutation of the gene located on the 6th chromosome was revealed. Despite numerous studies, the pathogenesis of celiac disease has not been fully elucidated. There are 4 theories of celiac disease: enzymatic, viral, pathoreceptor, and immunological. Clinical picture of celiac disease is very diverse. There are 3 forms of the disease: typical, classic, atypical, little symptomatic, and latent asymptomatic. The typical form manifests itself clinically 1 to 4 months after the introduction of gluten-containing foods into the diet. It is characterized by 3 main symptoms: polyphycalia, abdominal enlargement, which is observed constantly while the abdomen remains soft, reveals the symptoms of pseudoascites, growth retardation. A child who develops developed well in the first 6 months of life, by the age of 1 slows down the pace of development and lags behind their peers. In addition to the 3 main symptoms, children with celiac disease usually have others that can be quite variable. There are frequent manifestations of local enteral syndrome in the form of pain in the middle sections of the abdomen, nausea, belching, appetite disorders, but even more often symptoms associated with impaired absorption of vitamins, trace elements, and minerals. Diagnosis for the final diagnosis. It must be confirmed by 3 methods: immunologically, by the level of anti-gliadin antibodies, as well as autoantibodies to tissue transglutaminase, endomysium, reticulum. In practice, the first 2 methods are more often used. Clinically, according to the positive dynamics of symptoms after the appointment of a gluten-free diet, observation should continue for at least 6 months. The main treatment for celiac disease is a lifelong diet with a complete exclusion of all foods containing gluten. The gluten-free diet excludes products containing rye, wheat, barley, oats, bread, confectionery, pasta, semolina, oatmeal, pearl, barley, sausages, and sausages of lower grades, sauces, meatballs, breaded dishes. An additional appointment of drug therapy may be indicated at the first stages of treatment for malabsorption syndromes. In case of severe malnutrition, nutrition is corrected, vitamin and mineral deficiency is prescribed, calcium and vitamin D3 preparations are prescribed. With symptoms of local enteral syndrome, enzyme therapy is indicated to optimize abdominal digestion, prion, licase, pancreas, and correction of intestinal dysbiosis, bifiform enterolinex, for example. The course of treatment is usually 1 to 2 months. Thank you for your attention.